Our today's one of the important topic is IVIG beyond GBS. Now I would like to invite Dr. Gurudash Mandal, Associate Professor of Neurology NIMS, to talk on IVIG beyond GBS.
Honorable Chairperson, my respected teachers, dear colleagues, welcome to all to my presentation. Today's presentation is on IVIG beyond GBS. Immunoglobulin is derived from plasma and used in the treatment of the primary and secondary immunodeficiency state and some autoimmune and inflammatory disorders. There are some terminology. We are very much confident to the term IVIG, but there are some terminology which are cited to my presentation. Not only this, it is used widely and some are FDA approved. Among this, beyond IVIG, subcutaneous immunoglobulin, IMIG, hyperimmunoglobulin. Nowadays, it is used in COVID and anti-D immunoglobulin like RSA, ABO incompatibility group. As we know, chronic inflammatory demyelinating polyneuropathy, it is the most common chronic autoimmune peripheral neuropathy group of disorders having chronicity, demyelination, inflammation, immune reaction. Motor involvement is greater than sensory. Response to immunosuppressive therapy. Early administration is important because if the treatment is not started early, then axonal degeneration will not be minimized. Importance of this slide is that in case of GBS, as we know, GBS, variant of GBS, treatment is not same, prognosis is not same. In case of CIDP also, we have a general thinking that this proximal distal weakness, CIDP, start steroid, failed immunoglobulin, plasmaxine, etc. No, it will be categorized. Either it is typical or variant because treatment option is not same. Even which is patient indicated in CIDP may be contraindicated in atypical form. That's why this is important. Here, if the disease is mild, just observation. In case of functionally significant deficit, 3 options: not steroid, no response IVIG, no response plasmapheresis, not like that. This one of these 3 can be started from the very beginning. It is the latest recommendation. সেক্ষেত্রে IVIG 0.4 gram per kg 5 days এবং 3 weeks interval follow improvement, relapse এবং later on prednisolone, that is gradual IVIG দিয়ে tapering করে পরে prednisolone যেতে হবে। আমি শিডিউলটা পরে বলছি। In case of prednisolone 60 to 80 মিলিগ্রাম দিয়ে স্টার্ট করে ইমপ্রুভমেন্ট দেখে পরে ট্যাপারিং এ দিতে হবে। প্লাজমাক্সিন এটাও 6 weeks ইন্টারভ্যাল প্রথমে দিতে হবে, ইমপ্রুভমেন্ট হলে ট্যাপারিং এ যেতে হবে। In case of severe disease, প্লাজমাক্সিন 6 weeks দিয়ে, কিন্তু এই ক্ষেত্রে প্লাজমাক্সিনের সাথে prednisolone from the very beginning স্টার্ট করতে হবে। In case of CIDP, treatment option induction therapy and maintenance therapy. In case of when we shall start it, I have mentioned when more than mildly affected or mildly affected rapidly orthotic, intravenous immunoglobulin should be given. In small study, among these 3, no significant, only simple, 60 to 70% they studied. They have seen that intravenous immunoglobulin, plasmaxine, steroid, almost same response. It is around 50 to 70% improvement if it is started from the very beginning. Initial dose depends on many conditions like comorbidities, availability, route of administration. My previous speaker have mentioned the merits and demerits of IVIG plasmapheresis. here, in case of atypical form, IVIG is not first line. In this case, rituximab but monosteroid therapy are preferred.